Welcome to Why Words Matter Through an Internal Medicine Lens. My name is Dr. Sandra Miller. I'm a Senior Medical Director on the Revenue Cycle Solutions team at the Advisory Board Company. I have over 20 years of experience working in the healthcare industry. The key objectives for today's session is to develop an understanding of the role that documentation plays in determining patient severity of illness, risk of mortality, and how this impacts physician quality scores. Also, we will understand definition changes and terminology changes within ICD-10-CM and ICD-10-PCS. And we'll understand the concepts of linking conditions and manifestations and greater specificity documentation for a more accurate depiction of patient status. First, we're going to spend some time talking about the overall importance of documentation and the basics of ICD-10-CM-PCS. What was once used as a tool for communication between physicians and a note-taking system is now a primary data source for a massive industry. The audience for your documentation has increased to include governmental agencies, insurance companies, and not to mention the patients and other caregivers that are now able to access the electronic medical record. There are mounting pressures for physician documentation because of the changing healthcare landscape and new payment models. These are driving increased scrutiny of clinical documentation in order to validate accuracy, quality, and value of the care being provided. And as you can see, some of these driving factors are the value-based purchasing penalties, obviously the transition to ICD-10, payment reform in general, and the overall sicker population that we're dealing with as hospitalists and internists. There is increased transparency for patients in sites such as Medicare.gov, PhysicianCompare.gov, HealthGrades.com. Even insurers' portals will have physician report cards for transparency. You now have a virtual reputation that can and will be accessed on publicly reported websites. This reputation is created from the data that is driven by your clinical documentation. There are a couple of concepts called severity of illness and risk of mortality that are important for you to understand. Your documentation drives severity of illness and risk of mortality level assignments. These metrics of severity of illness and risk of mortality are used to measure patient acuity and therefore drive expected patient length of stay and mortality rate. The clinical documentation drives the assignment of these levels. These levels are determined based on a number of factors including primary and secondary diagnoses, comorbidities, demographics, patient history, treatment and procedure delivered, and other patient-specific information. As you can see on this slide, documentation really turns the quality dial. This slide represents the impact that improved clinical documentation can have on observed versus expected mortality rates. The OE ratio, observed mortality rate over expected mortality rate, is an increasingly important metric in healthcare. And you can see how this hospital, prior to initiating a documentation improvement program, really was underrepresenting the expected mortality rate of its patients. And after their documentation improved, you can see how their expected mortality rate exceeded their observed mortality rate. This is a very favorable outcome of documentation improvement. So why go from ICD-9 to ICD-10? Well, in ICD-9, what happens is that our documentation is really tried to be matched up with a code that already exists. There's very little code building per se in ICD-10, in ICD-9. In ICD-10, however, the codes are built based on the documentation that exists in the medical record. So by doing that, it will help us provide better detail and a more accurate depiction of patient severity. It will help with management of patients. It also will help us obtain reliable and robust clinical data that can be used to help make data-driven decisions related to all aspects of healthcare, including payment for new procedures, capture morbidity and mortality data, the value of new medical procedures, and even help in global disease emergencies. Why so many new codes? Well, the main difference between ICD-9-CM and ICD-10-CM codes outside of the structural changes is the level of specificity of the code. And you can see here, particularly in the procedure codes, there's a significant increase because now we are able to capture such components as causal agent, laterality, type, approach, episode of care, and route operation, just to name a few. Here's what an ICD-10 CM diagnosis code structure looks like. And you can see the key documentation concepts that are required in this code: specific anatomic location, type, acuity, degree, episode of care, laterality, and a number of other concepts that may not relate to your particular specialty. There are some key concepts to capture in your documentation that we're going to spend some time on next. First of all, the concepts that are driving changes in documentation really are represented on this slide by these bubbles. And you can see from the size of the bubbles that some concepts happen more frequently than others, such as laterality, route operation, causal agent, complications, approach, type of vessel. Those things are all concepts that you should be thinking about as you're creating your documentation to make sure that you capture all of those elements within your documentation. It's important that physicians clarify incomplete, conflicting, or ambiguous documentation. Otherwise, a query or a clarification may be needed. And clarifications and queries are usually needed when the medical record is incomplete. For example, an abnormal lab test is noted in the medical record, but there's no notation of clinical significance of these results. Whether there's clarity around a diagnosis, if there's a suspected cause or a treatment plan that isn't clear. Consistency, where there's conflicting documentation between two or more treating providers with respect to a condition or diagnosis. And precision, where clinical reports and other clinical conditions suggest a more specific diagnosis than what is really documented. Remember, it is the attending physician's responsibility to make sure that the medical record is complete in all of these aspects. Remember that signs, symptoms, and test results should be linked to related diagnoses when available. Linking signs and symptoms to diagnoses may increase the severity of illness and risk of mortality in the inpatient setting. Remember, utilizing the terms probable, likely, or suspected are all acceptable in the inpatient record if that condition is monitored or being treated as if it existed. However, in the ambulatory setting, documentation regarding the patient condition should only be documented to the highest level known. So in a lot of instances in the outpatient setting, all you do know is the symptom because you're in the process of doing your diagnostic testing. So remember, in the outpatient setting, documentation of symptoms is appropriate. However, in the inpatient setting, that may generate a need for clarification or query. Remember that abnormal findings such as labs, x-rays, path reports, and other diagnostic testing cannot be coded and reported by the coding professional unless clinical significance is identified and documented by the treating provider. Remember, the attending physician is responsible for documenting all conditions in the progress notes and discharge summaries, and also for resolving all conflicts in the documentation. Within ICD-10, there's a significant increase in the number of combination codes available. These codes can help capture the highest level of complexity and acuity in publicly reported data. So linking clinically relevant conditions where appropriate is the key takeaway that physicians need to have from this slide. Remember, coders are not allowed to assume such clinical relationships unless the attending physician or other treating physicians document those relationships in the medical record. And some examples would be hypertension with heart disease or endocarditis due to Staph aureus. Using the terms like due to and with are important to indicate that these disease processes are actually linked together and have some sort of relationship clinically. Now we're going to spend some time going over some examples of internal medicine diagnoses that may be affected in ICD-10 CM-PCS. Here's just a list of some of the topics that we'll be covering. There are some changes in ICD-10 around acute myocardial infarction, and really the major changes around timing. If you understand the implications for MIs, the timing now includes a category called subsequent MI. The identification here of the timing of an MI is an important thing in order to capture severity and complications. It's not important that the physician be able to count exactly the number of days and document that specifically, but the key takeaway here is that if the date of the insult is known, that date should be included in your documentation, and the coding professionals will then be able to calculate and assign that acute MI to the appropriate category. Here's what an acute MI code would look like in ICD-10, and here you can see that it is identified as a STEMI MI of the anterior wall of the left main coronary artery. It's important to identify STEMI and non-STEMI, and I think for the most part this is something that we all do very routinely. It's also important to identify the specific wall of the heart, the specific artery, if there was TPA administered and at which facility. And a new concept within ICD-10 is the documentation of tobacco exposure in these patients. Remember that any complication of a STEMI or non-STEMI should also be included in the documentation. In ICD-10-CM, if you document the 3 letters AMI, this will automatically default to a STEMI. If that's not what you intend, then you really should be utilizing the term STEMI or non-STEMI to indicate the type of acute MI in your patient. Topics of atherosclerosis, angina, and acute coronary syndrome also undergo some changes in ICD-10. In ICD-10, it assumes that angina is due to atherosclerosis unless you otherwise say differently. Acute coronary syndrome sequences now to a nonspecific diagnosis and may not necessarily reflect the non-STEMI or STEMI MI that you intended when you wrote the term acute coronary syndrome. So once again, specificity in your diagnosis is very important. Clarifying ACS and angina can impact the severity of illness and risk of mortality of your patient and create a much better clinically significant picture of what your patient looks like from a clinical standpoint. Here's what a code looks like for coronary artery disease with angina. And one thing that I'd like to point out here is that these codes in ICD-10 are built very logically. They start very broadly with the topic of chronic ischemic heart disease, and then they slowly, as we learn more through our diagnostic testings, can add more specificity such as vessel type and type of angina. So some doctors might have noticed that both unspecified options do exist for vessel type and angina, and the question is, why should I document more specifically if a coder can code without it? And the answer here is that you want to reflect the actual diagnosis that your patient has with the greatest level of specificity that you can. This is important not only for the completeness of the medical record, but also for continuation of care of that patient so that other providers have direct, accurate, and appropriate data surrounding your patient's condition. Remember that specificity drives severity. Vessel type and angina type matter. If you look at this particular slide, this really is representing how specificity and documentation can identify what is called a comorbid condition. This is a secondary condition that's classified as a condition that impacts severity of illness, risk of mortality, may impact reimbursement, but also impacts metrics such as length of stay. And you can see by utilizing the unspecified term of angina, it really adds no severity of illness or risk of mortality to your patient as that record is coded. But as you become more specific, documenting unstable angina or angina with spasm, you can see this adds an additional level of severity of illness and risk of mortality to your patient. Heart failure is one of those areas that we tend to take shortcuts on, but in all honesty, heart failure can typically be documented much more specifically than what we currently do in our day-to-day practice. So components for best practice documentation around heart failure include specifying acuity, specifying type, clarifying any relationship with underlying diseases such as hypertension, identifying, if known, any underlying etiology of that heart failure, and if there are any diagnostic tests such as echocardiogram findings that support the diagnoses that you've documented, to make sure that those are included in your discharge summary and notes if available. We talked a little bit about comorbid conditions, and now we're going to add a topic called major comorbid conditions. And these are things that actually increase severity even more, increase risk of mortality even more, and probably increase length of stay expectations more. So to capture severity of illness, make sure that you're very specific in your documentation. And one thing that you can note on your slide is that adding the term acute really adds another level of severity to your patient's clinical condition. So you can see here that systolic heart failure, when documented like that, is a comorbid condition, but if it's an acute episode of systolic heart failure, that adds another layer of specificity. So remember that specificity matters in your documentation, and you should always document to the greatest level of specificity that you know. Here's what a heart failure code looks like in terms of ICD-10. Remember that if a patient has hypertension and heart failure and the physician feels that there is a causal relationship between the two, it should be documented as such. For example, hypertensive heart disease with acute systolic heart failure. Tobacco exposure is a concept that is getting a lot of attention in ICD-10 simply because now we have a code set that's able to capture all the various levels of tobacco exposure, and it's really important specifically for diseases of the pulmonary, cardiac, head and neck, and during pregnancy. Document the level of usage, such as exposure, use, or dependence, and document the type of usage. Is it environmental tobacco smoke or secondhand smoke? Is it current usage? Is it dependence? Or has the patient quit and has quit for a number of period of time? Asthma also has taken on another level of specificity that's now able to be captured in ICD-10. And you can see the various types here, intermittent or persistent. Acuity is important to document, mild, moderate, or severe. And then any complications, so the with part of your documentation, with an acute exacerbation or with status asthmaticus. Also remember to document, if present, any exercise-induced bronchospasm, cough variant asthma, or any other just generic wheezing that you are not really sure whether it's asthma at this point or not. And you can see what the code would look like for someone with severe persistent asthma with an acute exacerbation at the bottom of the slide. These concepts are now aligned with the National Heart, Lung, and Blood Institute guidelines for asthma. Bronchitis is an important diagnosis that we see frequently, and the key documentation tips around bronchitis is to document the acuity, the type of condition, whether it's chronic asthmatic bronchitis or chronic obstructive bronchitis, and if you happen to know the causal organism, that's always very important. Remember, always document any tobacco exposure in these patients. COPD and emphysema, again, has the reminder to always document tobacco exposure, and then also document whether or not there is an acute exacerbation, whether there's any specific type of emphysema present, and also other considerations may include whether or not there are chronic obstructive bronchitis included with it, or it may be due to inhalation of chemical gases or fumes. So any other complicating factors or things that may have contributed to that patient with COPD's exacerbation is important to include in your documentation, because now in the ICD-10 coding world, we have the ability to capture that level of detail within the code set itself. Pneumonia and influenza documentation concepts both require documentation of tobacco use. Remember to identify the organism, link any associated conditions to the pneumonia, such as influenza with secondary gram-negative pneumonia or sepsis due to pneumonia, and remember, if aspiration is present, to identify the agent that is probably responsible for that aspiration, such as food, solids, or liquids, or some chemical pneumonitis exposure. In terms of influenza, make sure that you document the type if you know it, and also include those associated conditions as I mentioned earlier. Here's what an ICD-10 code looks like in terms of a patient with methicillin-resistant Staph aureus pneumonia. Respiratory failure concepts are very important. Remember, documenting respiratory distress does not equal documenting respiratory failure. Remember to document the acuity, acute on chronic, or the presence of chronic respiratory failure. Specify whether there's hypoxia, hypercapnia, or it's unspecified. And remember to document that exposure use. One new concept that occurs in patients that are placed on mechanical ventilation within ICD-10 is the ability to stratify based on time spent on mechanical ventilation. This is not to say that the physician needs to calculate these particular consecutive hours, but instead the physician should make sure that included in the documentation is the date and time of intubation as well as the date and time of extubation. If those pieces of information are included in your documentation, your coding professional will then be able to stratify the patient into the correct duration category and assign the appropriate ICD-10 code. Transient cerebral ischemic attack documentation really is looking also to have documented any associated stenosis that may be present. It's important, if you can, to specify the artery if you know it. Also, if there are any other known vascular syndromes or carotid artery syndromes, it's important to include that in your documentation, and also to link that diagnosis to any underlying cerebrovascular disease. CVA documentation is important, and I think we all make sure that we document whether or not TPA was given, but we may not document in which facility it occurred. So that's an important concept to remember. Again, remembering to document the acuity, the laterality, and a new concept in ICD-10 is documenting the hand dominance of the patient. This is important because it really does indicate the severity of illness of that patient and the level of rehabilitation that it may take for a patient who has a stroke on the side of their right hand dominance. Their rehab will be much more intensive than someone who is affected on their non-dominant side. Remember to document the site of the non-traumatic intracerebral hemorrhage and document also whether there's hemiparesis or hemiplegia. Cerebral infarction documentation should also include whether or not it's embolic, thrombotic, or due to stenosis and occlusion, and the artery that's affected. The Glasgow Coma Scale can now be captured in ICD-10, and the important thing to remember here is to not just generally document the overall total Glasgow Coma Scale, but to document the score for each of the 4 separate categories in the Glasgow Coma Scale. This is probably not something that as an internist you would do frequently, but maybe your patients may undergo this with a neurologist or in the emergency department. You can see on this slide those areas that are highlighted in red are areas that would be categorized as a major comorbid condition and add a lot more severity and risk of mortality to your patient as that record is coded. Diabetes is a topic that we take care of frequently in internal medicine, and really physicians should document the type of diabetes, any underlying condition that the diabetes may be due to, and whether or not it is related to gestation. If left unspecified, diabetes is going to default to diabetes type 2 in ICD-10. We should also indicate the use of insulin in these patients and document any manifestations or complications. So documenting type 2 diabetes with foot ulcer is an example of linking those manifestations or complications back to that diabetes. Utilizing the terms with diabetes hyperglycemia or diabetes with hyperosmolality is very important and a way to capture severity of illness and risk of mortality. Also, utilizing the term diabetic, such as in diabetic nephropathy, helps to also capture the severity of illness and risk of mortality in those patients. When diabetes is documented as inadequately controlled, poorly controlled, or out of control, it is going to be coded as the type of diabetes as it is, either type 1 or type 2, with the complication of hyperglycemia. If that's not what you mean, then your documentation should really be more specific to indicate the actual diabetic manifestation that you are talking about. Clearly linking diabetes with its manifestations and complications is a way to capture severity of illness and risk of mortality. And it's important to think about kidney and renal manifestations, ophthalmic manifestations, neurologic, circulatory, and any other manifestations. Or it could be a diabetic that currently does not have any of these complications as described above. Malnutrition is an area that affects a lot of the patients that we take care of, but our documentation around the severity of malnutrition is really pretty nondescript at present time. This is something that's very important moving forward in ICD-10, and we should keep this in mind because really various types of malnutrition can affect how well our patients respond to therapy. Moderate protein-calorie malnutrition is considered a comorbid condition, as well as mild protein-calorie malnutrition. If you're unsure how to categorize these patients in terms of their malnutrition, certainly your nutrition consult or your dietitian should be able to help you stratify these patients. There are multiple key components to documenting malnutrition, and I think the key takeaway on this slide is that just because the BMI is reported in the medical record does not necessarily clarify that as the diagnosis that's associated with the BMI. So, for example, having a patient with a documented BMI that's greater than 40 does not mean that the patient will be coded with a diagnosis of morbid obesity. For that to occur, the physician actually has to attach the term morbid obesity to that BMI level to indicate to the coder that that is a clinically significant diagnosis that should be captured. Additional documentation should be present to support the diagnosis of malnutrition, which includes obviously the history, the exam, any diagnostic testing, and any treatments in place, as well as any dietitian notes that you may have. The malnutrition criteria that your current dietitian uses is based on the American Academy of Nutrition and Dietetics and American Society for Parental and Enteral Nutrition. This slide is just meant as a refresher of what those categories might mean and might help you identify a patient who might be suffering from malnutrition. Pressure ulcers are something that we also see frequently, and it's very important to specify stage, laterality, and site of the ulcer. It's also very important to specify the severity. Stage 3 and 4 are very important, and it's also important to document whether that pressure ulcer was present on admission. Here's an example of what a pressure ulcer code would look like in ICD-10. It's critical to specify excisional versus non-excisional debridement in these patients who have ulcers. This may not be a procedure that you do, but it may be something that you have requested a surgical consultant to do, and you want to make sure that they're documenting the procedure accurately, to make sure that they're utilizing the term excisional if they are certainly cutting away dead or necrotic tissue. It's also important for the documentation of the instrument to be included, the location, and the depth of tissue that's removed. Also, for CPT coding in terms of excisional debridement, the surface areas should be documented as well. Here's what an excisional debridement code would look like, and you can see that the root operation here is listed as excision because that is clearly how it was documented in the medical record. There are some concepts around anemia that are important to capture in ICD-10. Obviously, acuity, the type, whether it's nutritional, hemolytic, aplastic, and the etiology, if it may be related to drugs or chemotherapy or malignancy. If the anemia is secondary to hemorrhage associated with the procedure, the documentation should really specify if this was a complication or expected outcome. Remember that the documentation of acute blood loss anemia does not trigger patient safety indicator 9. Neoplasms are important and also have some very specific documentation concepts. Specifying the site is very important, and specifying whether it is a primary or secondary neoplastic location. Laterality is important. Functional activity in the neoplasm is also important to include. So if the neoplasm has any endocrine activity, it's important to include that and link those two conditions together. And then always document the behavior of that neoplasm, whether it's benign, malignant, in remission, or cured. Link complications and comorbidity. So, for example, anemia due to neoplasm or a pathologic fracture of the vertebrae due to neoplasm. Again, we're using the terms due to and with as appropriate to identify that linkage between the neoplasm and another complication or comorbid condition. The best practice documentation for neoplasms include documenting when they're in different locations in the same site, or if they are overlapping. We previously called that contiguous. We need to know, for example, which lung and which lobe. Is it a tumor or mass? And the question always arises, what is the difference? In ICD-10, a mass is just considered to be equal to a lump of unknown etiology or unknown specificity. It can be something as simple as a fibroma or a ganglion cyst. The term tumor indicates that you're talking about a neoplasm. Lack of clarity in documentation on primary versus secondary sites will generate a query for more information from your coding professionals or your clinical documentation improvement professionals. Kidney disease is another area where documentation is very important in ICD-10. It's very important to document acute renal failure or acute kidney injury and include the with if it's known, such as with tubular necrosis or with acute cortical necrosis. Most times you may not have that information, so you cannot include it, but if it is available to you, it should be part of the medical record. Identifying the stages in chronic kidney disease is very important. If chronic kidney disease is related to hypertension or diabetes, that linkage should be included utilizing the terms due to and with. And also, if the patient is of transplant status, that should be included in the medical record. Documentation about sepsis, severe sepsis, and septic shock are important, and they all have varying levels of severity of illness and risk of mortality. Remember that the term bacteremia is simply reflective of an abnormal lab finding and is considered a sign and symptom and does not represent a systemic process. If sepsis is present or septicemia is present in a patient with bacteremia, it should be documented as such. It's imperative that the physician clarify if the patient has a systemic infection, sepsis, or if the patient only has the finding of bacteria in the bloodstream. Remember, sepsis documentation should include the underlying local infection, identifying any specific or suspected organism, and linking or clarifying if there's any associated organ failure or shock present. Remember, utilizing the term urosepsis in ICD-10 will generate a query since it will no longer default to a simple UTI. So that term urosepsis is really not something that is codable in ICD-10 and will require further clarification if it is used going forward. Severe sepsis is defined as sepsis with documented organ failure. So remember that documentation should include any associated organ failure such as acute renal failure due to E. coli sepsis. Septic shock generally refers to circulatory failure associated with severe sepsis. This documentation requires the systemic infection, causative organism, and identifying any other associated organism, and clinically there should be evidence that there is pressor agents being used to maintain vital functions. Documenting of digestive system diagnoses in ICD-10 really does revolve around those concepts in that bubble that we saw a while back. Documenting, obviously, the alcohol and tobacco abuse or dependence, being specific about the name, identity, and location of disease, and documenting any complications. Make sure to link findings to underlying conditions to get credit for severity of illness. Again, within the digestive system, remember to document acuity, link it to any anemia if present and applicable, link it to any underlying causes if known, and always document alcohol and tobacco use, abuse, or dependence. With all hemorrhages, we need to have the acuity and we need to have a link it to potential of anemia and the cause of the bleed. You can see that some of these recommended documentation documentation tips here to avoid a query on this slide, such as diverticular disease with hemorrhage or peptic ulcer with hemorrhage. You see the linkage between the hemorrhage as well as the underlying disease process. Here's just some more documentation tips around hernia and ulcer documentation, and you can see again these concepts are running through the same thing: site, laterality, complications, acuity, any associated conditions that may be present. Always remember to document any complications of rectal bleeding, intestinal obstruction, fistula, or abscess, and once again remember to document alcohol and tobacco abuse or dependence. Here's what a code looks like for a GI ulcer in ICD-10. There are a number of other GI conditions that you'll run across, but really the general concepts do not change, documenting specificity, acuity, laterality, complications, site, degree. All of those things are the common concepts that run through all of the various systems that we're going to talk about in this presentation. Here's what a code would look like in terms of acute pancreatitis. And again, documenting the importance of alcohol or drug involvement in the pancreatitis is important. Pain is an area where documentation also takes another turn in ICD-10. It's important to clarify whether the pain is acute or chronic, and whether or not the admission is for control of the pain or for an underlying condition that is causing the pain. Remember to link pain to the pain type to the condition. So it's chronic pain due to or limb pain from a right BKA. Remember also to include if there are any modalities that are being used by the patient to take care of that pain in the outpatient setting, such as a spinal neurostimulator. Here's what a code would look like in ICD-10 for an acute pain patient that has pain due to trauma. Substance abuse disorders are important to capture in ICD-10, again specifying the name of the substance, the type of use, the current status, whether they're in remission, intoxicated, or in withdrawal, and document also any behavior disorders that might be associated with the substance problem, such as anxiety, delirium, or hallucinations. Again, here is what a code would look like in ICD-10 for a substance abuse patient. Let's talk a little bit now and switch gears about best practice for procedure notes. We need to start now for developing a procedure note that captures ICD-10 PCS terminology. So here are some tips that are included, should be in every procedure note. The date and time, obviously the intended procedure, and the procedure performed. If there's a difference, the reason that the difference occurred should be included in the documentation. Remember to document any device that was utilized during the procedure, anything that made the procedure difficult or longer, any unusual findings, and any complications either accidental or due to maybe the patient's underlying medical conditions. Documenting complications of care really does change in ICD-10 because now we can more accurately identify when true complications occur. It's very important to document conditions that are occurring in the post-operative period, and they should be clarified as to whether or not they are expected post-procedural condition, an unexpected post-procedural condition that is unrelated to the surgical procedure, an unexpected post-procedural condition related to the patient's underlying medical comorbidities, maybe such as chronic obstructive pulmonary disease, or an unexpected post-procedural condition that is related to the surgical care, a true complication of care. Here's some documentation around procedural complications, and one thing that we need to document is whether or not the complication occurred intraoperatively, post-operatively, or is a late effect. And also something new is to document the encounter, initial, subsequent, or sequela. Remember, ICD-10 PCS is only used for inpatient procedures. Any procedures that are done on the outpatient or ambulatory side will still be coded utilizing HCPCS and CPT codes. So let's review some best practice documentation teaching points. Around documenting an acute MI, define or document the exact date of the insult so the coders can identify the appropriate category to place the patient's MI in. Remember that acute MI defaults to STEMI and ICD-10 unless you otherwise specify it. When documenting heart disorders, remember to name the type of valve and the disorder that's observed, and specifically around patients who present with congestive heart failure, specify the acuity and type of congestive heart failure that's observed. Remember to carry all significant findings, either from labs, x-rays, or path reports, into the progress notes and discharge summaries so that they are captured and included in the coded record. Remember that documentation around pneumonia requires a suspected organism, whether or not aspiration may have occurred, and whether or not the patient might also have sepsis. Remember, documentation around influenza requires the type of virus if it's known, and any link to any other diseases or manifestations that may occur. Conflicting, incomplete, or ambiguous documentation will definitely lead to a query or a need for clarification, so it's very important to make sure that the medical record is complete at the time of the patient's discharge. Remember that documentation of tobacco exposure is crucial in ICD-10, particularly around patients who are suffering from pulmonary, cardiac, GI, or pregnancy-related conditions. Again, there are more tips on this slide that hit some of the highlights of all the slides that we talked about. The key here is to always link conditions to complications and comorbidities and to avoid nonspecific diagnoses and include the most specific documentation that you can. The more specific your documentation is in the medical record and discharge summary, the less likely you will receive a query or the need for further clarification from your CDI specialist or your coding professionals. So circling back to the concepts that drive the majority of changes, there are concepts such as laterality, root operation, complication, causal agent, approach. If you remember these things going forward in your documentation, and certainly you can use those today as well as when ICD-10 becomes active, it certainly will help capture the severity of illness and reflect the good quality of care and the severity of illness and risk of mortality of the patients that you're caring for. In this slide presentation is an appendix that includes some case scenarios that will further delineate some of the topics that we talked about, and also some definitions of some of the new terminology around procedures that will be used in ICD-10. Thank you so much for listening to Why Words Matter through an internal medicine lens.